Hello, I'm Nigel Stephens. I'm a consultant cardiologist, and I'm here to say a few words about atrial fibrillation, or as it's commonly abbreviated, AF. It's the most frequent heart rhythm abnormality that we look after, and it's something about which there's a lot of myth as well as quite a lot of complexity as well. It's something that happens to all of us if we get old enough, and it's almost to be regarded as a feature of the normal aging heart. It occurs because the collecting chamber of the heart, the left atrium, instead of having a regular rhythmic electrical activity, suddenly starts to behave in a chaotic way. So millions of electrical microcircuits start to circulate within the atrium, and the heart continues to beat, but frequently in a rapid and chaotic way. When it first happens, people are often very aware of it, and it's a very uncomfortable sensation, and it typically takes away maybe 20% of the efficiency of our heart action, and so people will often report their hearts beating rapidly, erratically. They may be breathless, they may be fatigued. When somebody like me sees somebody with atrial fibrillation, they ask themselves a whole series of questions. So one of them is, why might this have happened? We need to rule out an overactive thyroid gland, which is a common catch and easily missed if you don't think of it. And after that, we need to think, is it an electrical thing of itself in an otherwise healthy heart, almost a feature of normal aging, as I said? Or is it perhaps a genetic abnormality, particularly if it occurs in a younger person and running in a family? Or perhaps it's the first outward sign of underlying heart trouble. So when we see somebody with AF, we would talk to them, examine them, do some blood tests, including thyroid function, record an ECG, and do a heart scan called an echocardiogram. The AF may be intermittent or there all the time, and so sometimes we do a prolonged period of ECG recording, which is called a 24-hour ECG or Holter monitor. The echocardiogram is a very powerful test for us. It allows us to understand about the structure of the heart, whether the heart is damaged, whether the heart is working normally, and whether the valves of the heart are malfunctioning or not. After we've made this initial assessment, we need to think about treatment. Treatment can get complicated. We often start in a simple way by giving a medication to slow and regularize the heart. One of the oldest drugs used in medicine is digoxin, and we would often use that for this purpose. The next important thing for us is to decide whether the person is at risk of a stroke because of blood clots forming within the atrium while the person has atrial fibrillation. We're all indebted to a nice man called Greg Yip, who devised a scoring system for us called Chad's VASC, and that allows us to work out what the person's risk of suffering a stroke or other similar complication. Thereafter, we can balance the risks of blood thinners versus the benefits of prevention of blood clots. After we've made these initial attempts at treatment, for most people, we would then aim to put the heart back into normal rhythm. We would give blood thinning medication for 6 weeks, along with the digoxin or similar drug, and have the person in hospital for a brief period of time to flip the heart back into normal rhythm. We do this with an electric shock, which is delivered under quite heavy and strong sedation so that the person is unaware of what we're doing. And for all comers, there's about a 75% chance that that will be successful, and a similar 75% chance that it will remain successful. So that's the first 2 steps of treatment, and they would be offered for most people unless there are other aggravating circumstances. If we've discovered they've got underlying heart disease that the AF is a feature of, we need to address that in its own right. And common examples would be heart valve disease or heart failure. For some people, medication doesn't work, and for some people, cardioversion doesn't work or doesn't maintain a benefit. For a proportion after that, we would think about a more technology-based approach called ablation. Ablation is designed to go inside the heart in a keyhole procedure and electrically isolate the parts of the heart that are responsible for generating the AF. It's not a perfect procedure. It's done under general anaesthetic. It can last quite a long time and does have a small but definite risk of complication. For people whose lives are blighted by the AF, or there is some other important reason to get the heart back to normal rhythm, ablation would be our next step. For many people, however, we might accept the AF if the person's quality of life remains good.